नहीं
क्या है?
ठीक है नहीं उसके बाद दम लगता है आप लोगों को।
सही है,
हाँ भी है।
थोड़ा करो आगे तुम। ये भी आने तेरा,
बिल्कुल।
तू कैंची ले लेना। तू इतना क्यों कैंची दे?
हाँ,
थोड़ा टाइम फैन चला।
वीडियो नहीं चल रहा है, वीडियो नहीं कनेक्टेड है। खराब हो गया क्या? नहीं सर, इसको थोड़ा ऊपर कर रहा है, ऊपर ही करना बस। ना
चाह पीनी।
ये बंद करें प्लीज, ये जो ऑटो वाला है ना, इसको प्लीज बंद कर दीजिए। ओके सर, तो अब नहीं होगा नहीं ट्रांसक्रिप्शन? नहीं वेटिंग रूम नहीं, वो करने वो सबटाइटल फोन करने ट्रांसक्रिप्शन बना रहा है। ये अलग से देखो, ये लिख के आ रहा है ना, ओके सर न्यू क्या लिख के आ रहा है सब, ये ट्रांसक्रिप्शन बंद कर दो। ये मोर के बगल में ना, हाँ, उसके बगल में सीसी करके है ना। हाँ good evening everyone, and welcome to Mahamana case discussion series. For today's session, we have the session on cutaneous malignancies, and we have Dr. Sanskruti Murthy with us. She's the director of Arion Radiotherapy and Oncology Center, Bangalore, and she'll be presenting on the management of cutaneous malignancies.
Hi, Azim, Dr. Azim, and the entire team. Thanks for the invite. Am I audible or?
Yes, you are audible. You may share your screen.
Is that visible now?
Yes, it is visible.
Okay. Good evening, everyone. Today's my invited talk is on management of cutaneous malignancies of head and neck. I'll be focusing on.
Sorry to interrupt. Can you please just put it on the slideshow mode? It's not in the presentation mode. Maybe you can put the play button on that. It's a Apple.
Yeah. Okay. Is this, I think, yeah. Now is it better?
Yeah, this is fine.
Okay. So the topic for today is on management of cutaneous malignancy of the head and neck. When we look at the anatomy of the skin, we can see that the skin is made up of various layers like epidermis, dermis, and hypodermis, and within which we have various pleomorphic tissues like sebaceous glands, we have veins and arteries. So when we look at the tumors that arise from the skin, there is a wide array of pathology that comes from it. The most commonest being melanoma, which we are not going to be talking about. And the next, the least commonest are the non-melanoma tumors, where squamous cell carcinoma and the basal cell carcinoma of the skin are the commonest tumors that present in the cutaneous malignancies. However, various sarcomas like angiosarcomas or adenocarcinomas arising from sebaceous glands, cutaneous lymphomas also do exist, but we will not be talking about them today. So when we look at the literature that is available on cutaneous malignancy, we can see that most of it does not arise from India. Why is that? Is because the incidence of cutaneous non-melanoma malignancy is extremely low in India. When we look at the global scenario, we can see that the Western Pacific belt has the maximum incidence of cutaneous malignancy. However, in India, the same when in the Western world, we can see that it is seen on the age adjusted ratio is almost 2 to 5, while in India it falls almost up to 6.2 in males. Even when we look at when we compare ourselves with our neighbors like Chinese or Malaysia, we can see that even within Asia, Indians have the lowest incidence of cutaneous malignancies. This could probably attribute it to our skin pigmentation, which itself acts as a protective mechanism. So when we look at management of these tumors, we need to understand how they present clinically. Basal cell carcinoma commonly are called as a rodent ulcer. And when they're described morphologically, all the various subtypes do have been described, but most of the basal cell carcinomas are present as mixed type, where they could be nodular, they could be pigmented, and thus makes the diagnosis a little more complex at times. However, cutaneous squamous cell carcinomas most often present as ill-defined margins, with most often it is filled with crust and bleeds on touch. Although various other variants like adenosquamous or spindle cell carcinoma might make the diagnosis a bit more challenging. I'm presenting this collage of images just to show that these are all squamous cell and basal cell carcinoma, all arising in different sites of head and neck, and each comes with its own problems, with its own complexity of treatment, complexity of treatment decision making, and also its own reconstruction issues. Basal cell, be it basal cell or squamous cell carcinoma, both have to be the gold standard to diagnose them is a deep biopsy. We have to make sure the biopsy reaches the deep reticular dermis so that pathologically the whole thickness of the skin is visualized. In very few rare cases, we may need IHC to diagnose a basal cell carcinoma, that is BER-EP4 is what is commonly used to differentiate it from SCC and melanoma, especially in the pigmented variant. However, only in spindle cell carcinoma, which is a variant of squamous cell, is the only time when it can be confused with sarcomas, when we need cytokeratin or EMA to diagnose a squamous cell carcinoma. When we look at the guidelines, we can see the use of dermoscopy or conformal microscopy, but we should remember that these modalities are, although they are non-invasive, they're not routinely used in India, mainly because this is used only in high-risk conditions. It is used in high-risk population, mainly to screen and triage the patients and understand where to take the biopsy from. And either they're most often used in combination or alone, but their relevance in clinical scenario is quite limited. So once we know what the pathology is by the biopsy, we need to understand when do we image in cutaneous malignancies. When it is a superficial lesion, most often imaging is not required. But when we have large tumors, then imaging is required. So when do we require this? When we are suspecting bone invasion, which most commonly happens in scalp and periorbital region. Although clinical fixity gives us an obvious sign for bone involvement, but subclinical erosion is something that will be picked up by CT, and just clinical examination might not suffice. Periorbital involvement, again, clinical examination of orbital movement restriction or vision disturbances does give us an idea that the orbit is involved. But again, in early cases, especially when medial and lateral canthus is involved, we definitely do require CT scan or an MRI. MRI, T1 weighted contrast enhanced fat suppressed image is probably the best to understand early tumor involvement into the intraorbital fat. A tumor like this, where it is arising from the nasal vestibule, we need to, and there is, you can see there is a generalized subdermal extension of the tumor. In these kind of cases, we need to understand the deep soft tissue extension. And in these cases, we might have to do an MRI to understand to map the tumor disease. In high-risk cases, I will talk about risk stratification later. And when we suspect regional nodal metastasis, then again, we will need a cross-sectional imaging. This is more so true for squamous cell carcinoma than basal cell carcinoma. Although the diagnostic criteria when we do a cross-sectional imaging is similar to the mucosal head and neck squamous cell carcinomas. When we are suspecting perineural spread, or when it is a recurrent disease, or the tumor is arising in a re-irradiated skin, even in these cases, it is best to do a cross-sectional imaging to completely map the disease. So before we get into the treatment approaches, it is important for us to understand what are the practice guidelines that exist today, and also the various risk stratifications, because our preoperative workup, our treatment modalities and follow-up, everything is divided as per the risk stratifications. TNM and NCCN risk stratifications and practice guidelines is what we commonly use in clinical practice. Although various country-specific practice guidelines does exist from American, British, Australian, New Zealand guidelines do exist. But one of the main drawback of TNM risk stratification is that they do not take into account the anatomical site within head and neck. Immunosuppression is not accounted for. Pathological features are not accounted. Neither is the lymph node ratio or the recurrent tumors are accounted. When we look at the NCCN practice guidelines, we can see that all head and neck basal cell carcinomas are considered as high risk, along with features like poorly defined borders, recurrent lesion, immunosuppression, perineural invasion are also considered as high risk. When we look at risk stratification for cutaneous squamous cell carcinoma, we can see the literature has even a wider suggestion. We have Birmingham and Women's Hospital staging system. We have Salamanca refinement of the same staging. And although these do exist, again here, AJCC and NCCN is what we commonly see. But unlike for basal cell carcinoma, in squamous cell carcinoma, lesions that are less than 2 centimeter is considered as low risk, and anything between 2 to 4 arising in the head and neck region is considered as high risk. In squamous cell carcinoma, there is another category is very high risk, which when the tumor is more than 4 centimeters, when there are desmoplastic changes and depth of more than 6 millimeters, and when there is perineural invasion. When we are deciding on the treatment approach, we need to take into account the anatomical site, because involvement of critical structures like eyelid, lip, which are cosmetically very sensitive areas, make tumor removal without any cosmetic or functional impairment extremely difficult. The size of the tumor is again important, because larger tumors, that is very high risk tumors, are more prone for subclinical or subdermal growth, and makes getting negative margins extremely difficult. Involvement of surrounding skin, like this small image insert that I have inserted, where you can see this was actually a patient of chronic tinea capitis, and the patient actually, the main tumor is way more anterior. This patient presented even with distant metastasis and regional metastasis. You can see that the adjoining skin is chronically inflamed. In patients with actinic keratosis, the patients will have desmoplastic changes in the surrounding skin, or few patients who are more prone might have a second primary right adjacent to the primary lesion. So surgical resection is considered as the gold standard. So when we are considering our treatment options, we also need to check whether it is resectable and whether we can get negative margin in this patient or not. And the method of margin assessment has to be decided preoperatively. Involvement of the nodes has to be assessed in very high risk and high risk cases, and reconstruction options must be discussed. Why is anatomical considerations important is because especially the midface, periorbital and periauricular regions are considered complex. They even in the literature, they have shown the highest recurrence rates compared to all other subsites in the head and neck, and they also have a greater cosmetic and a functional concern. However, nasal and nasal and sorry for the spelling mistake, that is a perialar tumors, they are also very difficult because the surgical access, especially the inner side of the alar process, makes it even more difficult for us to get access. As similar to the image that I had shown previously, you can see they are more prone for subdermal spread, and they're also most often more prone for high risk for recurrence. So when we look at margins, even before we embark on how we resect these tumors, it is important that we get a negative margins and what are the implications of it. Basal cell carcinoma, the rate of positive margin is extremely varied in the literature, which ranges between 5 to 56%. And the most recommended negative, which is considered as negative margin, ranges between 3 to 7 millimeter in the literature. For squamous cell carcinoma, we can see that the suggested margins is between 4 to 6 mm, but there is no consensus, especially in cases of high risk and very high risk cases. Please remember that these margin assessment, what is considered as adequate margin does change in patients with where they have a second primary, or in cases of immunosuppression, the margins can be lower than what we consider as adequate. So as previously mentioned, surgical resection is the gold standard in managing cutaneous malignancies. Most micrographic surgery or complete circumferential, peripheral, and deep margin assessment with intraoperative frozen section is considered as the gold standard. This is mainly because there are various studies, not just in melanoma, but also in basal cell carcinoma and cutaneous squamous cell carcinoma, where most micrographic surgery and complete circumferential margin assessment has shown better margin control compared to doing a routine resection and a follow-up bread loafing. The recommended margins for squamous cell carcinoma, as described before, is 4 millimeters for low risk. It is 6 millimeters for high risk, and there is no adequate margin considered for very high risk cases. So what are the methods of margin assessment? Mohs micrographic surgery was described by Dr. Frederick Mohs in 1930s. So how does this differ from what we do normally? In normal bread loafing method is what we commonly use in head and neck. What happens when we bread loaf the tumor is that every section might represent a different portion of the margin. So supposing if we take a right lateral margin, a part of it might represent a right lateral margin, but at the depth, it might miss the tumor in the lower half of or at the base of the tumor. But in a most micrographic surgery, the tumor is resected with a bevel edge, and the tumor is resected like a cone, with the cone pointed downwards towards the base of the deep depth of infiltration. So by doing this, when we take out a single section along one of the margins or on one of the quadrants, a single section is going to show us from the bottom till the depth of the tumor. In a single section, you can assess the whole margin in a single section, which is not possible by routine bread loafing. Although when we look at our NCCN guidelines, they also have described another technique called the muffin technique, which I have never done. But in this technique, they have compared this technique to a muffin because it is like a muffin that is kept in a muffin cover. So the main central tumor is completely debulked. So that is like the muffin being resected. And the muffin cover is when the tumor bed margins are taken separately and sent for pathological evaluation. Be it the muffin technique or be it the classical Mohs micrographic surgery, remember the margins are assessed immediately intraoperatively with a frozen section. Unlike the conventional method, although muffin technique also describes using the same for with permanent paraffin blocks also. So there is another technique called torte technique. So that is again compared to another pastry where it is similar to the bread loafing method, but here the circumference of the resection is marked, and the loafing is again done beveled so that the I don't think I can. Sorry, the peripheral rim is taken out, and the central portion of the tumor is bread loaf like the classical pathological evaluation, and the rim which represents the outermost margin from the from the skin to the depth is again examined in the single layer. So immaterial of what technique we use during resection, we should always remember that the margin assessment technique has to be discussed with the patient because it has a huge financial implication, and also the same has to be decided preoperatively, and the pathologist or the dermatopathologist has to be informed beforehand before embarking onto the resection of a cutaneous malignancy. So how do we manage, this is about resecting the primary tumor, but how do we manage the neck? The overall incidence of nodal metastasis in squamous cell carcinoma is approximately 5%, but this incidence is much higher in immunosuppressed. So when do we suspect lymph nodal metastasis in squamous cell carcinoma? It is most often when the tumor is more than 4 centimeters, or when the depth of the tumor is more, including the subcutaneous fat, when the tumor is poorly differentiated, when there is increased inflammation around the tumor, showing peritumoral inflammation, when there is lymphomascular invasion, perineural invasion, and when the lesion is recurrent, we should suspect a nodal metastasis. So how do we manage when there is nodal metastasis? When there is when it is a high risk and a very high risk category of patient, we should consider doing a selective neck dissection. Even when the single node is involved, a selective neck dissection has to be considered, and when more than one is considered, lymph node is positive, then a comprehensive neck dissection has to be involved. When superficial parotidectomy has to be done, when that is the first echelon group of lymph nodes. And parotidectomy, please remember, when I mean superficial, it is the plane that is superficial to the retromandibular vein, because that is the watershed area for the lymph nodes and not the facial nerve. The radiation therapy to the neck is not recommended as the primary modality of treatment, and chemoradiation therapy is indicated in pathologically nodes that show pathological extranodal spread. Although there is no evidence for it, it is mostly extrapolated from the mucosal head and neck malignancies. Nodal recurrence is usually seen 10 to 19 months from the duration from the treatment of the primary disease, and the rate of nodal metastasis and distant metastasis is up to 4 to 27%. And we should suspect parotid node involvement when there is lesion involving the anterolateral part of the face. Do we have any role of sentinel node biopsy in head and neck? Probably limited, mainly because although it has shown promising results in cutaneous melanoma, its value in cutaneous squamous cell carcinoma, especially in the head and neck region, is limited, mainly because most of these tumors do drain to parotid nodes, which is the first echelon group of lymph node, and sampling a node from parotid will result in performing a superficial parotidectomy, mainly because of the risk of facial nerve involvement, and is also less cost effective than doing a prophylactic neck dissection in high risk cases. So is there role for definitive radiation therapy in non-melanoma cases? Yes, but only when surgery is not possible. A randomized controlled trial, especially for basal cell carcinoma, measuring less than 4 centimeter, has shown promising results, but we have to always remember that these outcomes is much lower than the surgery. However, for squamous cell carcinoma, there is no proof that compares the role of definitive RT as a primary modality, but it is still reserved for cases that are inoperable and in candidates who are not candidates for complete surgical resection. In elderly patients and patients who are with poor performance status and multiple comorbidities, definitive radiation does still have a role. Adjuvant radiotherapy again is, although there is lack of level 1 evidence, most of the prospective case series and studies have shown benefit with adjuvant RT, especially in high and very high risk cases. Adjuvant RT has shown an improved loco-regional control. Dose fractionation and use of cisplatin concurrent with RT is based on the evidence from the mucosal head and neck squamous cell carcinoma. So when do we use systemic therapy? We use it only in cases, again, in cases of inoperable disease, unresectable diseases, or when cases of distant metastasis. As I said before, cisplatin, carboplatin, or cetuximab are common regimes that are used either it can also be used in concurrent setting. But the recent evidence has suggested that semiplimab, pembrolizumab, are the two immune checkpoint inhibitors which has shown promising results. Where for basal cell carcinomas, Vesmotimib, Digib have also shown promising results. But in a recent meta-analysis, they have shown in a metastatic setting, Digib has shown promising results. However, in squamous cell carcinoma, a recent phase 2 trial has shown up to 51% of pathological response in neoadjuvant setting with semiplimab, and has also been FDA approved recently for use in the neoadjuvant setting. Although Keynote 629 has shown similar results with pembrolizumab, but this has been only in locally advanced unresectable and metastatic setting. To conclude, basal cell carcinoma, standard excision with 4 margins is what is recommended. Radiotherapy and non-surgical modalities and superficial modalities are restricted only in cases that are not surgical candidates. When there is positive margin, we should consider re-excising the lesion, especially in basal cell carcinomas. And even in high-risk cases, the standard of treatment still remains surgery in basal cell carcinoma. And again, in basal cell carcinoma, in high-risk cases, when the margins are positive, re-resection has to be considered over RT. However, the treatment approach for cutaneous squamous cell carcinoma is different. Here again, for low, high, and very high risk cases, surgical modality is considered as the main treatment modality. However, if the margins cannot be revised, even here adjuvant RT along concurrent with cisplatin or cetuximab can be considered in the adjuvant setting. systemic therapy is reserved only for non-surgical candidates. Thank you. I'm sorry I could not put up the references completely. For residents can scan to get the whole list of references.
So, thank you, Dr. Sanskruti, for the lecture. I know this was a very less discussed topic that we had put up today, and thank you for taking up this topic. And we will also be having a further discussion on the next session on non-melanomatous, on the melanomatous malignancies of the skin. And now we'll proceed with the case discussion. And for the case discussion, I'd like to invite Dr. Sudhir Nair. He's professor and head of the surgical oncology at ACTREC, Mumbai. Dr. Shilpi Sharma. She's associate director and head of surgical oncology at Max Super Specialty Hospital, Dwarka. And Dr. Shikhar Sahani. He's assistant professor at Amrita Institute, Faridabad. And the case presentation shall be done by Dr. Simran Dhanua. She is a MCH resident at TMH Mumbai. Do we have all the examiners here?
Yeah, thank you, Asim, for calling me for this particular thing. Yeah, I am. Please, am I audible?
Yes, sir, you're audible.
Okay.
Dr. Shikhar, Dr. Shilpi.
Yeah, hi, Asim sir, I'm here. Thank you for inviting me.
Thank you, ma'am. So, Simran, you may please start the case presentation.
Yes. Good evening, everybody. I'm Simran, and we will proceed with the case presentation for a cutaneous malignancy. My patient is a 64-year-old gentleman who is a resident of Meghalaya. He's a known case of diabetes and hypertension and is a gardener by occupation. He presented to our OPD with the chief complaint of a painless, non-healing ulcer over the right side of the cheek since the last 6 months. At presentation, the patient was apparently asymptomatic 6 months back when he noticed an ulcer over the right side of the cheek, which was insidious in onset. It is a gradually progressive in size from approximately 1 cross 1 centimeters initially to its current size. He also gives history of change in color around the ulcer since the last 2 months. There is no history of any associated pain, no history of itching in the region. There is no history of any discharge or bleeding from the ulcer. There is no ulcer seen over the other parts of the body or the face noticed by the patient. There is no history of any swelling over the face or in the neck. There is no history of any weakness on the right side of the face. That is the involved side. There is no history of any significant weight loss and no history suggestive of any distant metastasis. In the past history, there is no history of a similar illness in the past. He is a known case of diabetes mellitus on oral hypoglycemic agents and a hypertensive patient on oral medication as well. There has been no history of a prior surgery or hospital admissions. There is no history of any known allergies, no prior treatment taken for the said complaints, no significant family history is there for the patient, and no history of a recent contact with the person with any skin lesion, and no history of recent travel has been noted by the patient. As for the personal history, the patient is not a tobacco chewer or a cigarette smoker. There is no history of alcohol consumption. He's been married for the last 35 years. He's a non-vegetarian. The bowel and bladder habits are normal, and he's a gardener by profession. He uses sunscreen when it comes to sun protection, but does not use any sun protective gear. To summarize, my patient, Mr. X, is a 64-year-old gentleman, known case of diabetes, mellitus, and hypertension, gardener by profession, who presented with chief complaints of painless, gradually progressive, non-healing ulcer over the right side cheeks in 6 months with no other associated symptoms. On examination,
Can I
yes,
ask a question here? You
yes,
know,
sir.
what is the role of family history?
So certain cutaneous malignancies and lesions have a genetic predisposition. To name a few, we have xeroderma pigmentosa, sir. Patients who have genetic abnormality in chromosome 9q are at a higher proposition for cutaneous malignancies and a higher UV-induced damage. Then other syndromes could be a Gorlin-Gore syndrome, sir, in which patients have multiple basal cell carcinomas, that is nevoid basal cell carcinoma syndrome. Some other one other syndrome associated is the Bazek's syndrome, also in which the patient has multiple growth abnormalities, multiple vertebral and rib-related abnormalities, and risk of cutaneous malignancies as well.
So what will be the typical presentation of a xeroderma pigmentosa?
Sir, the patient would present to us at a very early age, and the patient would have history of multiple prior treatments if he has taken any, and multiple prior lesions as well. The patient would have dry, scaly skin, discolored skin, with telangiectasias and scaling and disseminated lesions all over the skin, sir, with history of intolerance to the sunlight as well.
Okay, we'll continue.
Dr. Simran, what is the
Yes,
risk of cutaneous malignancy in xeroderma pigmentosa? Hello, am I audible?
Yes, ma'am. I'm sorry,
There is
ma'am.
how many
for
fold
second.
increased risk of cutaneous and how many fold increased risk of non-cutaneous malignancies?
I'm sorry, ma'am.
Okay, so that is important. So this year at least, risk of cutaneous malignancy is to the tune of 1,000-folds when you have xeroderma pigmentosum, and non-cutaneous malignancy, it's about 10 to 20% increased risk. One more thing I
Yes.
want to point out before moving on to examination, repeatedly you have mentioned that there is a lesion ulcer on the cheek. Now,
Yes, ma'am.
is it the cheek or it's the skin of the face?
Ma'am, skin ulcer only, ma'am.
Yeah, so because when you say cheek ulcer, cheek is traditionally considered as inside the buccal mucosa,
Inside.
on the buccal
Okay.
mucosa or inside mouth. So if I have not seen patient, it's giving the appearance that you're talking about a buccal mucosa ulcer.
Okay.
It
Yes,
could
ma'am.
be
I'll
ulcer on the
edit it, ma'am.
face and or skin of the face.
Yeah, even I was
Yes,
also
ma'am.
thinking it was a buccal mucosa tumor because you mentioned it as cheek, so I was thinking like it's a buccal mucosa.
I'm sorry, sir. Skin over the cheek, sir.
Okay.
So it would be skin over the face would be a better term
Okay. Yes, ma'am.
if it is on the external skin of the face, right?
Yes, ma'am.
Another thing is on the basis of history, what are the risk factor for skin malignancy? Is there any risk
Ma'am, in the
for
patient.
patients?
Yes, ma'am. The patient has the patient's profession puts him at a higher risk for developing a cutaneous malignancy, ma'am. He works in the sunlight for approximately 4 to 6 hours per day, and has been doing so for the last 25 years, ma'am.
So, there are two risk factors. One is a occupation.
So the patient's geographical location, sir, he stays in a hilly area which has high propensity of receiving UV radiation as well, sir.
And the previous speaker also mentioned certain, from Meghalaya and all, they are more of a
Yes, sir.
southeast city.
In a hilly area, sir, they're more propensity of having UV induced damage, sir.
Skin tone will be different. So how will you classify the skin tone? You have any idea?
So for classification of skin, we have a Fitzpatrick grading, which is 1 to 6. 1 from the lightest, 6 to the darkest. So 1 is the Celtic type skin, which burns. Sir, 2 we have light European, 3 we have dark European, in increasing tendency of having a tanning. Sir, type 4 is a olive skin, in which the patients tend to have tanning and less of a burning. Type 5 is a brown color skin, and type 6 is a black skin, sir, which does not burn, and does not tan. Brown skin does not burn and does tan, sir.
So you need to also mention that skin tone in the history.
Yes, sir. In examination I've written.
Okay, go ahead.
Dr. Simran, can you go back to your negative history, the slide with the negative history?
Yes, sir.
Yeah, you've mentioned no history of itching and no history of ulcer over other parts of the face or body. Any significance of that?
Sir,
Why
itching
did you
could
ask this
be
history?
So it could, the patient's primary complaint could also be associated with the sensory symptoms of itching. If the lesion is, if the ulcer is deep enough to cause a somatic the neuropathy and a somatic sensation, the patient could give history of itching in that same area is it itself, or if the patient has uh, uh, if the patient has a skin condition which could lead to the person doing persistent itching and repeated trauma to that same area, the patient could have resultant ulcers over the parts of the face, predisposing the patient to a traumatic induced ulcer and further at risk for any
So
cutaneous malignancy.
you've tried to rule out chronic ulceration as a risk factor here, right?
Yes, yes, sir.
So
And
Yes, sir.
in this case, I will also ask one more question. I mean, what is ABCD?
yeah, that's what I wanted to know.
Sir, yes, sir. Sir, ABCDE is sort of a checklist that we use for a pigmented lesion that the patient has had for a longer period of time to determine if there is any change in the character and the morphology of it to associate it with a possible malignant transformation, sir. So, sir, the A is um, asymmetry, B is border, C is the color change, D is increase in diameter, and E is the evolution over time, sir.
Okay. Okay, please go ahead with the no further questions, I think. Please go ahead
Yes.
with the examination.
Yes. Yes, sir. Sir, on examination, the patient is calm, conscious, oriented to time, place, and person. He's of average build. His Fitzpatrick grade scale is 2, sir. He's an ECOG 0 patient with vitals within normal limits, with the patient being afebrile, pulse rate being 86 beats per minute with regular rhythm and a good volume. The BP being 130 by 80 millimeters of mercury in a sitting position measured in the right arm. The respiratory being 16 per minute. There is no pallor icterus cyanosis, clubbing edema, or generalized lymphadenopathy noted. On inspection, the lesion is over the right side of the face, skin of the face over cheek, overlying the body of the mandible, 4 centimeters in the angle of the mouth, and approximately 6 from the tragus. It is 2.5 cross 3 centimeters in size with an ulcerative area anteriorly of 1 cross 1 centimeters. It is asymmetric in shape. The surface is irregular with areas of ulceration and flat pigmented area around it. It is a single lesion over the right cheek with a small macular lesion in front of it as well. Also, multiple maculae have been noted over the right temporal region till the eyebrow. There is in the center, there's an ulcer with a non-sloping edge, and no slough is there in the floor of the ulcer. There is no discharge or bleeding at the time of examination, and intraoral examination was NED. Also, no facial swellings were palpated. Sorry. On palpation, the inspectory findings are confirmed with the size of the lesion being 2.5 cross 3 centimeters with ulceration at the anterior edge and surrounding flat pigmented area with induration at the anterior border as well. There is no local rise in temperature. It is the non-tender lesion with irregular surface. It is not fixed to the underlying structures. There is no discharge expressed, no bleeding on palpation. Soft macular lesion over the temporal area without surrounding induration or tenderness are also noted, and no palpable swelling in the preauricular area is there. On examination of the neck, the trachea is central. There is no visible scar mark or sinuses, no dilated veins, and no visible swelling in the thyroid region or the lateral neck region. And on palpation, the trachea is confirmed to be central with a normal laryngeal framework. Carotid pulses are palpable bilaterally. There is no palpable swelling in the thyroid region and no palpable swelling in the lateral neck region as well. On systemic examination, there are no similar lesions noted over other parts of the body. The chest and the CNS and CVS examinations are within normal limit. So tissue diagnosis has been done for the patient. The report is still awaited. We do have an imaging for him that he presented to us with. In this, the focal thickening over the skin over the right cheek has been seen without any deeper infiltration or muscular involvement or any suspicious adenopathy. To summarize, my patient is Mr. X, a 64-year-old gentleman, known case of diabetes, mellitus, and hypertension, a gardener by profession with a painless, gradually progressive, non-healing ulcer over the right side cheek since 6 months, with no other associated symptoms of with a 2.5 cross 3 centimeter pigmented asymmetric lesion with ulceration without involvement of any deeper structures and no palpable facial or neck swelling.
So, can you tell us your differential diagnosis and possible diagnosis?
Yes, sir. Uh, so the differential diagnosis for this could be it because of the non-healing nature of progressive increase in size over time, and patient having predispositions to leading to a cutaneous malignancy. It could be one of the non-melanomatous or a melanomatous lesion of the skin, sir. Possibly basal cell carcinoma, followed by a squamous cell carcinoma, or a cutaneous melanoma as well, sir.
What is Fitzpatrick scale?
Ma'am, Fitzpatrick scale is for the skin, is a scale that we use to grade the skin coloration of a person depending on how much they tan and whether or not they have burning of skin when exposed to the sun. It goes from 1 to 6, ma'am, with 1 being the Celtic type skin, 2 being the light European skin, 3 being the dark European skin, 4 being the olive type skin, 5 being brown, and 6 being the black skin, ma'am. In increasing tendencies towards the patient having increasing tendency of patient having the melanin, and decreasing uh, tendency towards sunburn, ma'am.
So here you mentioned that it is what is your most possible diagnosis? It's melanoma or basal cell carcinoma? What are the different types? Can you tell us different cutaneous malignancies which are commonly appearing in the head and neck region?
Yes, sir. So the different cutaneous malignancies could be melan a non-melanoma skin cancer, or a melanomatous skin cancer, or a lesion of the adnexa in the skin. So
Mhm.
non-melanomatous skin cancer, the most common types are the basal cell carcinoma and the squamous cell carcinoma. In the melanomatous is the cutaneous melanoma, and disorders of the adnexal diseases could be the sebaceous carcinoma, Merkel cell carcinoma, um, sarcomas, angiosarcomas.
Okay, and sometimes it may arise from the skin follicles, so benign and
Yes,
okay. So in this case, what is your primary first suspicion, and then what could be this?
sir, my first suspicion is more towards the basal cell carcinoma
Why do
because,
basal cell carcinoma?
sir, the patient has a longer history of development and the lesion being there with not a very progressive increase in size, and there is clinically the lesion is a superficial lesion without any associated facial or neck swellings. That is a nodal mass. It more so looks to be a basal cell carcinoma, sir.
What is how will you? What are the features of a basal cell carcinoma? When you say it's a basal cell carcinoma, generally what are
Sir,
features you look for in that particular lesion?
yes, sir. So basal cell carcinoma morphologically is also divided into 5 types, sir.
Hmm.
The most common type usually is the nodular type, that is the rodent ulcer that we talk about, which grows as a uh, elevated uh, uh, elevated papule that can tend to ulcerate in the center and have nodular rounded edges, hence the name rodent ulcer. It could also be a superficial scaling type of lesion, sir. Um, so it could be a morphiform lesion in which it is mostly a pale type of lesion, but indurated and raised edges with a deeper surrounding involvement. Mm,
Okay, so what type of this, if it is this particular thing? I think there is a some sort of reddish appearance on the picture you have shown. Can you show the picture?
Yes, sir.
Yeah. Is this because of the biopsy or is it because of the ulceration?
No, sir, he presented with this ulceration.
Okay. Suppose what else it could be?
Sir, it could be a cutaneous melanoma as well, that
So
with the irregular borders and now with central ulceration.
hmm. In case of a melanoma, what are the different types of melanomas you see?
Yes, sir. Uh, so the different types of melanomas are again a nodular type of lesion, a superficially spreading melanoma, uh, lentigo-maligna melanoma or amelanotic melanoma, and invasive desmoplastic variety as well, sir.
Shilpi and Shikhar, you can ask questions.
Yes, sir.
Please go ahead. Yeah.
Simran, you showed us the picture of the face or the lateral side. There are multiple similar melanotic
Yes.
patches on the
Yes.
temporal region as well. Why would you? What makes you think that this is the most suspicious lesion and not the others?
Uh,
And why would you call
sir,
this a malignant ulcer and not the others?
sir, the patient has given history of those lesions being present since much longer time without any change in the character of the same. Whereas this one specific lesion, he started noticing increase in the size as well as peripheral discoloration, which earlier was not there. So this one lesion at present points more towards a malignant lesion per se, sir.
And the ulceration as well. There's no ulceration in any other lesion, right?
Yes, sir. The yes, sir. The others don't have any ulceration, and this lesion has induration around the lesion as well, more so anteriorly, sir. Whereas the other are soft and
Is this was a pre-existing lesion or it just newly appeared? Because he has lot of, as Shikhar was telling,
Hmm.
lot of melanotic or some blackish patches. Is this the same thing which
he's
or it is a
no, sir. So 6 months back, he gave a history of a small papule type lesion only, which was approximately 1 × 1 centimeters. Then is ulceration and change and discoloration as well now since last 2 months, sir.
So, with this history of a new lesion for the past 6 months only and growing to this size, would that take you towards one particular diagnosis, given the differential diagnosis that you gave? Is 6 months history good enough for a BCC?
The BCC would have a longer history, yes.
Yeah. So, in 6 months, if a new lesion has appeared like this and it has grown to this much size, I would be scared. BCC usually
Yes.
will have a longer history, I would say.
Yes, sir.
Yeah.
BCC will be having a longer history and this actually there are multiple blackish patches all around.
Yes, sir. Yeah.
One of them it could be we in melanoma generally people look for the observe for any change, evolution of the
Yes, sir.
whether it is color variation, change in the diameter, ulceration, newly appearing, all those things, that evolution of the disease is very important. And asymmetric, border
Yes,
asymmetry
sir.
also important. I mean, I'm just
Yes,
saying
sir.
different other aspects we need to consider. Though BCC is, which is the commonest malignancy, cutaneous malignancy in the head and neck area.
So basal cell carcinoma.
Yes. So you can suspect that because that is being the commonest. Melanoma, not very so common, but in people in the is there any geographical variation of melanoma in India? Appearance of melanoma.
I'm sorry, sir. I'm not aware.
Because in
I
yeah, tell me.
no, sir. No, sir. I'm sorry, sir. I'm not able to.
One more thing, Simran, looking at the picture, it looks like that there are papular lesions type also. Are these all macules or you have
No, ma'am.
papular also?
The lesion that is just anterior to the primary lesion is more of a papule, and the lesions near the eyebrow are macules, ma'am. The one over the temporal region is more of a papule.
So that you have to be, you have to mention that you have just written macules, no? So you have to mention.
Yes,
In
ma'am.
fact, if you can count, it would be a good idea instead of going vague when you are presenting. If you can count, you can just show 5 macule and 2 papule on this. Specifically, you can mention, and I think it would be a good idea to just make a point that there is no similar lesion on any the part of the face or scalp, because if he has multiple lesions, then you should not miss it. Because sometimes it happens. Out
Yes,
of all these lesions, not just one, but
Mm.
you may have 2, 3 lesions which are suspicious, and you have to biopsy all.
Yes, ma'am.
And even in examination where you have mentioned palpation and all, no? You just mentioned no swelling in the lateral neck. I think at MCH level, apart from that, you should also include one line that there is no significant palpable cervical lymphadenopathy. That gives us just, straightforward idea that we are not dealing with any regional lymph.
Okay, ma'am.
So I think the skin tones are different across various geographical locations, especially people from northeast. So they may have a higher. I don't have exact data, but I feel that they have different higher incidence of melanoma in that area compared to uh, the northern and southern part of India. Okay.
Okay.
So these are important because when you what are the different types of if it is a melanoma, what type of melanoma it could be? I'm just saying it may not be, but if it is,
Mm.
what are different types? I'm just asking different types of melanoma. Just want to know whether you know the different types of melanoma.
Yes, sir. So, a superficially spreading melanoma would
Yeah.
more so have more depigmented, various colored areas, and a nodular melanoma would have a elevated macule type discolored lesion, and invasive desmoplastic mostly presents as an amelanotic patch with areas of induration and is more locally aggressive. And a melanotic would not have that same discoloration, sir.
Okay. I think Ratan was asking, Dr. Ratan was asking, is it a lendigo around a temporal region? What is a
Not sure, sir.
lendigo? What is
Sir,
that?
it is a lentigo. So lentigo maligna melanoma is also a type of malignant melanoma in which there are histologically changes of atypical junctional melanocytic hyperplasia noted on histopathology, sir. In this, the patient is tends to have maculae which progress in character and have speckled pigmentation throughout a bigger patch of a pigmented area as well.
That is the malignant type. So if there are lentigo, what is it happens these spots, black, brown spots, which appear
Yes, sir.
and skin. Sometimes
Uh,
they can transform to malignant transformation can happen very rarely. Okay, so that's lentigo. So why this patient traveled all the way from Meghalaya to Tata Memorial Center? Had a biopsy outside or he just came directly?
no, sir. He came directly. No biopsy done. The biopsy done here. Report awaited yet.
Just wondering because why patient, how come the patient travel all the way? Somebody might have advised. go straight to data memory center. Is it that? If it is, yes.
What do you look in imaging, and which imaging would be preferable?
Ma'am, ideally, imaging is reserved for a lesion that is locally advanced and aggressive. For superficial lesions in which we are not seeing clinical signs of an aggressive disease like fixity to the underlying regions or a neurological involvement or any bone erosion, we don't per se.
Will you do imaging in this patient
If
or not?
we are suspect,
So
ma'am, clinically the lesion is really is not fixed to the underlying structures, I primarily would not have done an imaging for this patient.
And how would you assess the depth clinically?
The imaging does, in the end, help us with the extent of the lesion and to see whether or not the subcutaneous tissue is involved on the imaging, definitely. But
See, it is
as
an
per
ulcerative type of lesion. So I think it's a good idea to do
yes,
imaging
ma'am.
because it's not just has only proliferative component. And you have done also MRI, right?
So
CT, the patient had done CT, ma'am.
I will ask you
CT.
because imaging is important for multiple reasons. One is, of course, as telling, and second thing is, the you understand the depth of his thing, local involvement, extent of the disease, all those things. It can regional extent of the disease.
Regional lymph
All
nodes.
Yes, involvement, if any, can be assessed as well.
Yeah, suppose assume that the biopsy came as melanoma, okay, malignant melanoma. So now we will see what are the investigations. So you did the biopsy, came as melanoma, and and what are the other investigations you will do, and how will you stage this disease?
So the staging for melanoma, the T staging is a post-excision staging, sir, in which the depth is seen on the histopathological specimen and the T stage is given. The T staging for a cutaneous melanoma is PTT1, in which the lesion is less than 1 mm in thickness, divided into T1A and T1B. In T1A, it is less than 8 mm without any ulceration, and T1B is 8 to 1 mm. So T2 is a lesion with thickness 1 to 2 mm. Again, further T2A and T2B. T2A is without ulceration, T2B is with ulceration. Then T3 is a lesion which is of the thickness 2 mm to 4 mm, and again T3 and T3B, that is without ulceration and with ulceration. And then T4 is a lesion with thickness more than 4 mm, T4A and T4B, without ulceration and with ulceration.
So suppose this is 1.1
This
mm.
was for the T staging, sir.
1.1 mm. I'm just saying, suppose this tumor is 1.1 mm, and so what will be the stage?
Yes, sir. So the patient has a T lesion of 1.1 with ulceration. So it is going to be T2B, sir.
Okay,
PT2B.
very good. So in melanomas, always with or without ulceration, that is A and B. That is one important
Yes,
thing.
sir.
Any other biopsy, any other in molecular markers will you check?
Sir, in melanoma, immunohistory can also be done, sir. The lesions are positive for HMB45 and S100 if a melanomatous lesion, sir.
Any other IHC for melanoma?
Um,
You said HMB45, right?
yes, sir, HMB45 and S100 and MART1.
Yeah, Melan A, right?
Yes.
Melan A. I think that
These
is
three
more
are
common. Yeah, that is
three.
more commonly done.
Okay, sir.
Yeah. How would you take a biopsy of this lesion?
So, skin lesions can be biopsied as a shave biopsy, as a punch biopsy, as an incisional or an excisional biopsy. This is a relatively larger lesion, so excisional I would not go for. In one incisional biopsy from the most suspicious area with area of induration with a normal edge of the surrounding skin, I would take a incisional biopsy from the same. And the biopsy's
what
depth
about
should
the
be
depth?
enough to include the
Depth.
the biopsy's depth should be enough to include till the reticular dermis.
Yeah. Okay. Great.
Suppose it comes out to be melanoma. Any additional imaging would you like to do?
Yes, ma'am. Since melanoma has a higher, relatively higher tendency to have an aggressive course and possible nodal metastasis as well, I would do a CCT head neck for this patient.
What is the risk of distant metastasis in melanoma? Hello?
Sorry, ma'am. I'm sorry, ma'am. The percentage for cutaneous melanoma, I'm not sure, ma'am. Sorry.
So what did you say? You said CCT chest.
Head neck, ma'am. At least to look at the nodal
Why
burden
not
for the
PET
patient,
CT?
I would do a CCT.
Yeah, why not PET CT? If it is melanoma, melanoma is known to be highly aggressive, especially head neck melanoma. Why don't you want to do PET CT to rule out distant metastasis? In melanoma, it should be done. Correct?
Okay. Okay.
But yes, of course, if it is BCC or something, what is for this kind of lesion, what would be the first, kind of lymph node drainage basin? What would be the first HT on this kind of lesion?
Ma'am, for facial
For this
drainage,
lesion, just talk about this patient.
ma'am, parotid nodes and submandibular nodes, ma'am.
So then how will you see if you don't do imaging, lymph nodes and parotid?
Yes, ma'am. So imaging, ma'am. Head and neck imaging, yes.
So the another option, another way, suppose you are unable to do an MRI, what else? How will you quickly assess the nodal metastasis? Any other way?
Sir, locoregional ultrasound we can do.
Suppose, is it a sentinel node biopsy advised in these type of lesions?
So sentinel node biopsy has been advised for a cutaneous melanoma and for more aggressive squamous cell carcinomas as well,
For
sir.
this particular patient, we do sentinel for squamous cell carcinomas, tongue and buccal mucosa. This
Yes,
particular
sir. So,
you do sentinel node biopsy.
sir, sentinel node biopsy in basal cell carcinomas and low risks.
No, it is, I'm saying in a, not a basal. I'm saying we assume it as a melanoma.
Sir, in melanoma, sentinel node biopsy has been shown to play a role, sir. It better stages the patient and has been recommended as a procedure for the patients.
I will ask you the previous question Shilpi was asking. Where is the Eclair nodes which will come, if at all, these type of lesions?
So patients have intraparotid nodes.
Will you, what sentinel node biopsy will it benefit? It shows something.
So sentinel node biopsy, sir, mostly the cervical nodal metastasis it will help us with if the patient is not having a parotid node. But if the patient has a positive parotid node clinico-radiologically, there are chances of the chances of the patient having a neck nodal metastasis is already increased. But if the patient does not have any intraparotid node and we want to evaluate, sentinel node biopsy has a role when it comes to the cervical nodal metastasis.
Okay. You got any question to be asked regarding this?
I'm good for now, sir. Mm,
Will you treat?
Um,
yeah,
Dr.
let's say
Sundar?
it's not a melanoma. It comes out as basal cell carcinoma. What would your next step be? So the biopsy is BCC. You've done a CT. What would be your next step be?
So for BCC, the primary treatment modality is a surgical excision. As per the recommendations,
How would you stage it?
surgical technique.
How would you stage it?
Sir, BCC is staged as the size criteria itself. T1 being lesion less than 2 centimeters, T2 being 2 to 4, T3 being more than 4 centimeters, or having minor bone erosion, minor cortical bone erosion, or deep invasion, which is characterized as thickness more than 6 mm, or involvement of nerves in the region of size more than 0.1 mm or more than 5 nerves involved, and T4 being T4A being gross cortical erosion or marrow invasion, and T4B being gross perineural invasion and invasion till skull base.
T3 you've covered fully. Something about fat also? No? Depth?
So more than 6 mm, more than 6 mm is
Or
T3.
involve invasion beyond the subcutaneous fat, right?
Yes.
So then I mean, you need to clinically stage the tumor before you take this patient up for surgery. So if you have to do an imaging, would you do a CT or an MRI?
So MRI would give a better soft tissue evaluation for this patient. And if I'm not clinically suspecting, I would not clinically suspect bone erosion in this patient.
Yeah, you said it's a
So MRI
superficial lesion, nicely
MRI would be a
mobile.
better
You're not suspecting bone erosion. Then you would
MRI would be a
prefer
better
an MRI.
modality. Yes, sir.
one more question I will ask you. Suppose it is squamous carcinoma, it comes as SCC. What
Yes,
risk
sir.
indication will put?
Sir, the size is 2.5 centimeters, and it is a head and neck SCC, but it is not exactly coming in that H zone. It would come as a high risk squamous carcinoma.
Most of the head and neck squamous
Are
carcinoma
high risk, sir.
high risk carcinomas. So you just shouldn't
Yes.
that. So of course, at basal cell carcinoma, if it is basal cell carcinoma, good. How will you manage in case of a basal cell carcinoma? I mean,
So
even
the primary modality offered is surgical excision, and the surgical treatment of choice is ideally a Mohs micrographic surgery.
okay.
Yes. So, sir, a Mohs micrographic surgery is a type of a PDEMA technique in which the peripheral and deep on-face margins of the lesion are assessed. The other PDEMA techniques are Tübingen, Dot, and Muffin technique as well. Mohs micrographic being the most popularized technique. In this, we excise the gross tumor margin with the gross tumor with a margin of 2 mm in a conical fashion with 45-degree bevel of 45-degree bevel of the conical excision that you're doing, and the specimen is taken out. It is flattened so that the base and the edges are coming at the same level. It is marked at 3, 6, 3, 6, 3, 6, and 9 o'clock positions with different dyes, and it is taken for a frozen section, and horizontal cross sections are taken. Horizontal cross sections are taken, and we are able to evaluate the peripheral margin and the central margin, central base at the same in the same go. And because of while this pathological assessment is being done on a line diagram that has already been made of the patient of a face, we mark from where we've taken the excision, and we mark with the colored markers the same areas, so that if we have to go back and revise depending upon the report for the histopathology, we are able to do so in the same setting.
Okay. So that is the standard. Suppose you are not able to do. Do you do routinely most micrographic surgery?
No, sir. If most micrographic surgery, the facility to you is not available, a standard excision is also an acceptable
The standard,
acceptable treatment modality.
tell me the standard excision
Sir,
surgeon will take.
the standard excision, yes, sir. Sir, different margins are described. So margin of 3 to 7 mm has been described overall. But if a lesion is less than 2 centimeter, a margin of 4 mm is considered acceptable. A lesion which is more than 2 centimeter, a margin of 7 mm, 7 to 8 mm is considered acceptable in a standard excision of a BCC.
8 mm for a BCC? Are you sure?
I found a few articles saying the same. But
What I remember is T3, T4 or a high risk BCC, then 6 mm. Otherwise, 4 mm is enough. I
Yeah,
stand
yes,
corrected.
in those 4 mm is enough. But I found certain noting 6 and certain noting more than 6 as well.
I think
Sudhir sir?
yeah, I follow 6 mm
Yes, sir. Yeah, that's what.
because and mostly we follow the 6 mm and we'll anyway do the frozen section also. It's not like
Yes,
a
sir.
micrographic, but we'll just check it frozen section. But 6 mm is generally we do because yeah, so that is the usual thing. I don't know, I mean, since there are, I can, yeah, Shilpi, tell me.
No, please go ahead, sir.
Yeah. So this is what we generally do. Okay. Suppose the basal cell carcinoma you excised and
Can I just ask something related to the same topic?
yes, please.
So, Dr. Simran, you said that facility of Mohs microscopic surgery is not available, then we will go for convention. So, tell me what do you need for Mohs micrographic surgery? You described the procedure in detail. You started with the statement that obviously the standard is Mohs micrographic surgery. Have you seen any?
I have not, ma'am, so far.
And what additional thing you need to do Mohs micrographic surgery? Nothing. You just need microscope. You need a frozen section that you can easily get.
Yes, ma'am.
So then why we are not doing it?
Yeah, fine question.
See, this is I think in my opinion, I have also not seen, so sir is there, he can comment. I think it's like a very old technique which has been described. And now we have very good imaging. We know the fair idea about the depth. We routinely use frozen section. We are kind of more aware about oncological principles of surgery that you should have. We now realize the importance of margins. So even if it is described, very few center, I guess, will be doing. Plus, they say that classically, when you want to preserve the tissue, right, where it's really going to make too much of difference. Here in this area, I mean, what extra deformity you are going to get if you just give additional 2-3 millimeter?
No, yes, ma'am. Understood.
So you need to understand what is described in the books and what is being. I mean, MCH is not only about theory. You have to, speak to the examiners what is being done also. You can always mention, but I think it would be a good idea not to make such statement that obviously that would be the first choice if that is not a right way probably of answering anything else.
Okay, ma'am.
You
Dr.
should,
Sahil.
yeah, you should actually you should do what is the standard practice in the institution. Okay, that's what I asked. I
Okay,
don't
sir.
know TMH when I was in TMH. We never used to do. I don't know if
Yes,
it
sir.
changed. I was not aware. So that's why I was asking. So if the institutional standard practice, there should be a logic behind that, and there should be a reason behind that. As Shilpi told, it's not a very complicated way, but it is a time-consuming way of doing the micrographic surgery. It's a whole day. It's a lot of time-consuming. It's very carefully done, and so that you can get the optimal margin and without compromising too much, removing too much tissues. That's also one
Yes, sir.
advantage of having this thing. Now, my question is, in this particular patient, there are two ways, two things. Patients is concerned about a scar. He says, how will do the surgery with you know much less deformity. Okay, so how will you close the defect?
Mm.
You'll refer to the plastic surgeon. How will you close?
Simran sir is asking what are the ways of reconstruction, a cutaneous defect.
Mm. So we can go for the primary closure if the tissue laxity is enough even after the defect has been made, or we can go for a local advancement or a rotation flap. And this patient is an aged patient with a lot of lax skin around. We could very easily be able to get the tissue to advance into the defect, sir.
Yeah, I mean, I agree. Here in this particular location, it is you may be able to do, but sometimes it can cause some, tethering and other problems if you try for this thing. Some advancement flaps or, have to be done. Okay, so suppose patient is not willing, say that I don't want any scar in the face. Any other option?
Mm. So brachytherapy has been tried for cutaneous malignancies.
The diagnosis basal cell carcinoma, BCC.
Sir, sir, even cryo and everything will give a scar to the patient.
Considering non-surgical options, if you're sending for radiation, what kind of radiation would treat cutaneous malignancies?
The
Anything different from
brachytherapy,
the standard? Anything different from the standard photons that we use for oral cavity or any other head neck lesion?
um, surface molds, mats with the
Surface mold would be
radiant.
type of brachytherapy. I'm talking about EBRT.
Yes, EBRT. I'm sorry, sir.
Electrons, right?
Okay.
Electrons, because they have lesser depth,
Okay.
lesser penetration. That is
Okay.
classically used for, if at all, radiation is being used for
Okay.
cutaneous malignancies.
Okay.
So that is, I mean, just wanted that is another option for treating BCCs, though the initial modality is surgery is better choice, but suppose in a location is cause morbidity, or if the patient doesn't want, a scar, or, it can have some, doesn't want surgery, or patient is not feasible, not a suitable candidate for a surgery, then this can be an option to be considered. in case of a basal cell carcinoma, suppose it is a malignant melanoma. Okay, we'll have that also, and then we will close this discussion. Suppose this as biopsy came as malignant melanoma. Okay,
Yes, sir.
melanoma. Then how will you approach this case?
I would still go ahead with a surgical wide excision for this patient, sir.
Good. What type of wide excision? How much wide will you go?
So the margins depend upon the thickness of the lesion.
MRI
For
1 mm.
yes, sir. Sir, for lesions that are less than 1 mm, a margin of 1 centimeter is taken. For lesions that are 1 to 2 mm, a margin of again 1 to 2 centimeters taken. For lesions that are more than 2 mm, a 2 centimeter margin is taken when it comes to melanoma, sir.
So anything else? Melanoma. Local
And
nodes
offering the sentinel node biopsies. Yes, sir.
lymph nodes. Will you directly go prophylactic neck dissection, prophylactic dissection, or you go?
So sentinel node biopsy, sir. We can offer sentinel node biopsy for this patient.
That,
And if it comes to be positive, a completion to be done, sir.
suppose the sentinel node. Okay. Anybody else? Shikhar, you have any other?
What are the indications of adjuvant therapy? Suppose this comes out to be BCC.
Ma'am, adjuvant therapy is offered to a higher stage with the perineural involvement, with a poorer histology such as a basosquamous lesion, with the features of lymphovascular angioinvasion seen.
You need to know in detail indications of adjuvant treatment in all types of cutaneous malignancy, BCC versus this thing, cutaneous squamous cell carcinoma. That you must know.
Yes.
Okay, Simran, one more thing I wanted to ask. Previous question only. In case of melanoma, you told sentinel node. Suppose the node comes in the parotid area. What will you do? MRI shows one small lymph node in the parotid.
So we do superficial parodectomy for the patients with skin lesions, sir.
Instead of doing a sentinel node directly, you can go for a superficial parotidectomy also. Okay. Most of the time, that will be the usual modality.
We do the superficial parodectomy, yes.
Okay. So whatever you institutional practice, you say that first. Sentinel node is mentioned in this thing, but I'm not sure. Generally, because there are practical difficulties a lot of times. Even sentinel node that we need all the parameters like step serial sectioning and everything.
Yes.
Right.
Yes, sir.
So
Nuclear medicine department.
yes, all those things are needed. So I think that is important. I just want to highlight that, because there are a lot of students listening to that. Now, yeah, so if basal cell carcinoma, primary single modality surgery is that, and adjuvant treatment, margin positivity is one of the area. If there is close margin or margin positive, then try to avoid, in case of margin, you try to re-excise it if feasible.
Yes, sir.
Not feasible, then go ahead with the adjuvant treatment.
Okay.
It is feasible. Suppose you did a very wonderful flap, scar is settled and everything is, you don't want to disturb it, then we may have to give adjuvant treatment. That's the only option. So But that comes in a very rare situations because you have taken all the precautions to avoid a margin positivity. Okay, till unnecessary. Okay. And in case of a melanoma, what is the risk factor of, satellite? Sometimes there can be satellite diseases, right? And
Yes,
what
sir,
are
satellite nodules.
risk factors for nodal metastasis? For example, this type of patient, is it high risk for nodal metastasis? If it is melanoma, this particular patient?
Sir, a higher, a larger tumor size with
So it could be large tumor size,
more depth of invasion is.
yeah, larger depth, deeper tumors, ulcerations on the ulcerated tumors, lesions on the face, cheek. They all have higher incidence of metastasis, nodal metastasis compared to other lesions. Okay, so these are also
Yes.
important factors. I was telling now, I may in this particular tissue, I will do if it is coming as melanoma, I will do as parotidectomy also, superficial parotidectomy also. In case
Yes.
of basal cell carcinoma, I will not do any uh, other, only the primary excision. Okay, I'll go ahead.
Yes.
And in case patient is not willing for surgery, then we can refer for radiotherapy procedures. Yes,
Okay.
Uh,
Yes.
because
Simran, just one question. What are the high risk sites of cutaneous malignancies?
So the age zone has been described for a high risk site of cutaneous malignancies, it being the the eyelids, the eyebrows, um, the nasal bridge, the peritemporal areas, preauricular areas.
You're naming everything. I think it's
नहीं sir, there
ear
are
and
ribs
eyelid,
sir.
right? Ear and eyelid, I feel.
Sir, ear में preauricular area more so, the
Yeah,
eyelid sir.
yeah. If it's a
This
lesion in
will,
the eyelid, apart from the usual melanomas that usual malignancies that you just mentioned, what else would you be very mindful of?
so sebaceous carcinomas tend to present more so as eyelid lesion, upper
Yeah,
eyelid
yeah,
lesions.
yeah, yeah.
adnexal diseases, you need
Hmm.
to consider whenever in and around adnexal disease are more common. So that is to be considered. Okay.
Yes.
Okay, I think it is 7 o'clock. Any Shilpi, you have anything else to ask?
No, I think it is still 7 only. Okay, then I think we can just close. Start at 7:30.
Okay, thank you, Simran. Yeah, I mean,
Just
Asim,
one more thing, Dr. Simran, like you mentioned,
Yes.
this thing, electron therapy for BCC. For melanoma, any other option apart from surgery and radiation? Suppose patient says, I'm not willing for surgery at all. You do get sometimes they're afraid of tumor, will spread and this and that. Is there any other treatment available for melanoma?
Targeted therapies are there, ma'am.
Like,
Ma'am, uh, the if the lesion is BRAF positive, we have dabrafenib, ma'am, as one of the chemotherapeutic agents, and we have CTLA-4 targeting drugs, ma'am, with imiplumab and imiplumab and
any other things apart from the targeted?
is there a newer modalities are coming, Anna?
yes, sir.
Everywhere.
What is that? Then
Presenting also. So immunotherapy, no?
Uh-huh. Yes, ma'am, immunotherapy is there.
pembrolizumab.
Yes,
Nivo.
pembrolizumab has been shown
I
a role.
mean, changing the overall survival, increasing overall survival. But we in early stage lesion surgery is still the preferred modality.
Surgery is, yeah, always the preferred modality. Only when it's like
Large lesions, distant metastasis.
correct.
Okay. So sometimes there is a neoadjuvant immunotherapy is also nowadays it's upcoming. But now don't tell these things in the exam upfront. Like these are,
Yes,
for
sir.
towards the end of the discussion. So like now the examiner asking what are the newer times. So these are the things. But of course, as we mentioned, if operability, do go ahead with the surgical procedure. Unless the patient is not willing completely, not willing because of various reasons, then we can consider for melanoma, this type immunotherapy is an option. Whereas for basal cell carcinoma, radiotherapy is the option. Okay.
One
Okay,
last surgical question, Simran. If you
yes.
plan to excise this, right, this lesion, so how would
Yes.
you plan your closure, the final scar? Horizontally oriented, vertically oriented, oblique oriented? How do you decide that? Any particular considerations while closing such lesions?
Um, this patient has already a lot of um,
Yeah, loose skin, right?
vertical, vertical creases throughout. So possibly no
If I
orientation with those.
if I say orient the scar along the RSTLs, what would that mean? What is RSTL? RSTL. Any idea?
They're the I don't know how to describe them, sir, but
No, the full form of RSTL. You heard of that?
they're the tension lines along the face, sir.
Yeah. Relaxed skin tension lines.
Yes, relaxed skin
So
tension
you
lines.
need to orient your final scar along the relaxed skin tension lines, not perpendicular to it. Read about that.
Yes,
Okay.
yes,
Yeah.
sir.
Yeah.
Well done. Thank you.
Thank you.
So
Thank you.
thank you, Simran. Thanks a lot. You had yourself requested for a presentation on this topic, and thank you for bringing out this topic because that's quite an important topic which is often missed.
Yeah,
Thank you, sir.
Asim, it's a great. Thank you, Asim, for calling me. And I think it's a very often neglected topic because we see a lot of CFs, commercial carcinomas. These are small cases. Once in a while will come. It will cause confusion for even the consultants also occasionally. So it's a good revision for all of us.
For the next four sessions, we'll be having different topics that we have planned. For the next one, we'll be having the melanomatous skin lesions. Then we'll also be having the minor salivary gland tumors management and management of the major salivary gland tumors of the unusual salivary glands. So all those rare topics will be clubbed together for the next four sessions. And I thank Dr. Sudhir sir, Dr. Sudhir Nair sir, Dr. Shilpi Sharma madam, Dr. Shikhar Sahani, Dr. Sanskriti Murthy for the lecture, and Simran for your presentation. Thanks a lot. We shall be meeting once again after 2 weeks. Thank you all.
Okay, thank
Thank
you.
you.
Thank you.
Thanks, Asim.
Thank
Thank
you,
you.
Asim.